Good morning. This is Catherine Otto. We've got a great crowd here this morning. We're up to 67 people participating and going up on this beautiful sunny day. So I'm glad that not everyone's sneaking out to get in a run early. And go for your run after grand rounds unless you're in the hospital, and then you can just keep working. So this morning I'm pleased to introduce Jasleen Tawana, who doesn't really need to be introduced and that everyone knows her. But I think, we hadn't, maybe you don't all realize that, Jasleen is actually one of our homegrown cardiologists. She went to her undergraduate training and her medical school training at the University of Washington, and she graduated magna cum laude from the university. So one of our own, who then went off to Michigan, where many other faculty have been during their training for her residency, and came back to join us for her cardiology fellowship in 2017. So she's now in her third year of fellowship. She's been working in the heart valve clinic and has a great interest in heart valve disease. Next year, she'll be continuing as a faculty member, doing clinical research and on structural heart disease interventions, as well as some clinical work, and then transitioning to a fellowship in interventional cardiology here in Seattle with the hope of continuing on to interventional training in structural heart disease, which I'm sure she will do and be a wonderful addition to that group of interventionalists. So it's welcome to Jasleen, who's going to talk about, of course, the most important disease in the world, which is aortic stenosis. And she's going to really focus on the asymptomatic patient of severe aortic stenosis. So Jasleen, I'll turn over to you.
Thank you, Dr. Otto, and thank you everyone for joining for Zoom Grand Rounds this morning. I have no disclosures. So today I'm just going to talk about a frequently encountered disease in cardiology. Aortic stenosis is a common valvular disease with significant morbidity and mortality, especially as the disease progresses to a symptomatic state. We can see from this figure here that patients with aortic stenosis begin to have lower than expected survival fairly early on, with survival dropping off precipitously following symptom onset. So when we've historically thought about the appropriate timing for intervention, we've largely relied on symptom onset as being the right time to intervene. But the matter of trying to figure out, quote, the right time to intervene is just always based on whenever the benefit of an intervention outweighs the risk. And when valve replacements first came about, it made sense to wait until very severe symptoms because, of course, we weren't experts from day one at surgically replacing valves, and there were significant risks to the procedure. But with time, our interventions have gotten better and less risky, so we've shifted to performing valve replacement at the earliest sign of mild symptoms instead of waiting for those very severe symptoms to hit. And this innovation in treatment is really what's allowed us to reignite a conversation about the appropriate timing of valve replacement. The overarching goal of today's talk is to figure out if we can move this arrow just a little bit to the left in our current era. Now, we know that not everybody's going to benefit from getting an intervention super early on. And our goal today is just to specifically figure out which patients in the orange zone of asymptomatic severe aortic stenosis will benefit from early intervention and what tests or markers we can use to identify those patients. So I just want you all to imagine that you're in clinic and you're seeing this patient. This is a hypothetical case. It's a 68-year-old gentleman who's asymptomatic, and he's presenting from rural Alaska to establish care for a new diagnosis of severe aortic stenosis. And that's his valve and cross-section. It's heavily calcified and immobile. And the valve hemodynamics are shown on the right. They're very consistent with severe disease. There's a peak velocity of 4.6 meters a second, mean gradient of 45, and an aortic valve area of 0.8. He does have a preserved ejection fraction. So when you see this patient, you might think, well, how do we really know that he's fine to just go back to Alaska and we don't have to worry or think about him a little bit more? How do we know that he's not at higher risk for poor outcomes? And is he somebody that's going to benefit more from a valve replacement now as opposed to later? I just want you to keep in mind what you would do for this patient. Hopefully, by the end of today's talk, we'll just have some more tools that you can have in your toolbox when you think through managements for patients like him. So the objectives for today's talk are to review the current guidelines for managing patients, to discuss emerging methods and indices for risk stratification when it comes to asymptomatic severe AS, to assess the risk of mortality with standard care versus early intervention, and then to evaluate valvular interventions available and ongoing trials that are going to illuminate the path forward. Just going to take a few minutes to review the background. When it comes to etiology, the most common cause of aortic stenosis in adults is calcific, and that's a combination of calcification of bicuspid valves or trileaflet valves. And given that this calcification is secondary to a degenerative process, the prevalence of aortic stenosis, of course, increases with age. The focus of today's talk is going to be to discuss calcific aortic stenosis. From pooled epidemiologic studies, we can estimate that aortic stenosis affects about 12% of patients that are 75 years of age or greater. And in general, about 3.4% of patients in that age range have severe aortic stenosis. And if we take those patients that have severe aortic stenosis, about 30 to 50% of them are actually asymptomatic at the time that they're diagnosed. So this is the patient population that we frequently end up caring for in cardiology. And another thing that we have to just keep in mind whenever we're having a conversation about AS is that aortic stenosis is more than just a disease of the valve. It's also a disease of the myocardium. So with pressure overload, we end up getting left ventricular myocyte hypertrophy in order to compensate. This leads to a reduction in coronary flow reserve. Over time, we end up getting chronic ischemia and apoptosis of myocytes that get replaced with irreversible fibrosis. And even when global ejection fraction is maintained early in the disease process, these changes lead to a reduction of longitudinal function of the myocardium. All of these ventricular changes end up contributing to diastolic dysfunction, which over time can cause pulmonary hypertension. So in short, cardiomyopathy accompanies aortic stenosis. And just broadly speaking, when we evaluate a patient that has severe AS, our goals are straightforward. We want to treat symptoms, we want to prevent heart failure, and we want to prolong life. In the case of an asymptomatic patient, the latter two goals really just become central to our discussion. So let's just take a look at how this plays out by, again, just stepping back to our patient case. So you've seen this person in clinic, and then you might think, well, let me just turn to the guidelines to figure out how I'm going to treat him going forward. So for that, let's just start by reviewing the guidelines. So starting at the top, we like to closely follow patients that have asymptomatic severe AS. We see them every 6 to 12 months with an echo. And of course, history is really emphasized to evaluate for symptom onset because that's our trigger for when we consider aortic valve replacement. But it's also pretty important to just acknowledge that sometimes it's really hard to tease out symptoms because patients end up accommodating to their decreased exercise capacity. So they might still be going on their quote unquote daily walk, but later on, if you dig a little deeper, you'll find out, oh, maybe they're avoiding hills that they used to go on. I'm sure many of the cardiologists in the audience have encountered this and are vigilant for it. But if you're still on the fence of whether or not a patient's exercise tolerance has changed, then you can consider an exercise treadmill test. And then based on the results of the history and echo, you start walking down this algorithm. And patients who have indications for aortic stenosis, you can end up referring them, patients who have indications for surgery, you can refer them. And those indications include whether or not they're already undergoing cardiac surgery, if they have a depressed ejection fraction, specifically less than 50%, and they're low surgical risk, if they have very severe disease, so if their valve hemodynamics are greater than peak velocity of 5 meters a second or mean gradient greater than 60 millimeters of mercury, and they have low surgical risk, or if they have an exercise treadmill test that has decreased exercise tolerance or a drop in blood pressure. And lastly, if they have really rapidly progressive disease. And then if they don't meet any of these, then you go back through the circle again and again. So our patient doesn't really meet any of the indications that are listed, but of course he has not had an exercise test. Exercise tests are of course reasonable to perform, as I mentioned, for risk stratification because patients with an abnormal test are more likely to develop symptoms at a year and then have lower event-free survival at 2 years. However, based on retrospective studies from the US, only about 30% of patients with asymptomatic severe AS actually undergo treadmill testing, and up to 15% of patients that do get referred are unable to exercise. So frequently cited reasons for not referring patients includes limited exercise capacity, comorbidities, frailty, or advanced age. So for one reason or another, even if we want to risk stratify our patients with exercise treadmill test, we're sometimes unable to do it. So let's say our gentleman has severe osteoarthritis of the hip and he can't exercise and he doesn't do much physical activity, and it's pretty hard to figure out whether or not he's got a decrease in exercise tolerance. We still ideally want to try and figure out if he's at higher risk for adverse events before we just send him off. So to do that, we'll go over the emerging methods and indices for risk stratification. Let's just start by talking about BNP. We're generally all very familiar with it. It's often used in clinical practice for a variety of reasons. Most commonly, it's useful in diagnosis and risk stratification for patients who have heart failure. And because cardiomyopathy accompanies aortic stenosis, it's also been evaluated as a prognostic marker in aortic stenosis. So Nakatsuma and colleagues aim to evaluate the prognostic impact of BNP in patients that had asymptomatic severe AS. This is data from the current AS registry, which is this large retrospective multi-center registry in Japan that has nearly 4,000 patients enrolled who have severe aortic stenosis. They ended up evaluating a specific subset of 387 patients who were all asymptomatic, had a preserved ejection fraction, meaning a PEF greater than 50%, and none of them were planned to undergo an aortic valve replacement. They ended up obtaining BNP within 6 months of their index echo, so whenever they got diagnosed with severe AS. And then these patients were stratified into 4 different groups according to their initial BNP level. And you can see the groups are color-coded on the left. The primary endpoint was a cumulative 5-year incidence of heart failure hospitalization and aortic valve-related death, which was defined as an aortic procedure-related death, sudden death, or death due to heart failure that could have been related to AS. In general, the average age was 80 years of age or so. The majority were female. And we can see on the results that in general, there's a higher cumulative incidence of adverse events as BNP levels increase. And in Cox proportional hazard model, patients with a higher BNP level had greater risk for the primary outcome. And specifically, BNP greater than 300 had a 7-fold increased risk of the primary endpoint. And this was all adjusted for age, BMI, creatinine, and gender, so other things that we think could cause adjustments in BNP levels. Now, an even larger study evaluating the utility of BNP came out of Mayo Clinic in 2014. And one important thing that this group did was to normalize BNP for age and sex. They did this by dividing the measured BNP by the max normal for age and sex. And they also tried to specifically exclude patients that had BNP elevations for other reasons, like recent AFib with RVR or kidney disease. So this was a prospective study, and they had 564 patients with asymptomatic aortic stenosis. And these were patients that had moderate AS or worse, and all the patients had a preserved ejection fraction. They collected BNP at the time of diagnosis, and the primary endpoint was overall mortality. Generally, patients were average age of 74, fairly even split between men and women. If we look at the survival curves on the left, we can see that the higher the BNP ratio, the worse the overall survival that patients had. And in red, that's a BNP ratio equal to or greater than 3, which, as we can see, has the worst survival. On multivariate analysis, a BNP ratio equal to or greater than 3 was independently associated with nearly a 4-fold increased risk of mortality. Again, this was adjusted for a variety of things that could have also caused BNP elevation, including age, sex, BSA, AFib, creatinine level, ejection fraction, among others. So to summarize, BNP is independently associated with an increased risk of mortality. There are some caveats we do have to keep in mind. If you're going to end up measuring a BNP level in a patient, just know that comorbidities, age, and sex can all influence that BNP level. So if we get it, we have to be reasonably sure that the elevation isn't being caused by something else aside from valvular heart disease. The second caveat to kind of keep in mind is that we don't really have a clear cutoff for when to consider surgery. Now, based on the couple of studies that we've looked at, you might think, well, 3 times greater than the upper limit of normal may be the best way to go about it. And in fact, the European guidelines have kind of incorporated that. So let's evaluate another marker. As we discussed earlier, aortic stenosis can result in maladaptive left ventricular remodeling. Again, just starting at the top of the screen, left ventricular hypertrophy occurs in response to pressure overload. With time, we end up getting supply-demand mismatch. And at a cellular level, this is leading to diffuse fibrosis with infiltration of myofibroblasts and extracellular matrix expansion. And then eventually you end up getting myocyte cell death and replacement fibrosis that ultimately leads to heart failure and cardiac death. On cardiac MRI, late gadolinium enhancement is able to evaluate this replacement fibrosis. So we can try and use MRI to evaluate left ventricular dysfunction and its association with outcomes. Let's just start by convincing ourselves that late gadolinium enhancement on MRI does in fact measure myocardial fibrosis for patients that have aortic valve disease. This is a prospective study of 54 patients that were scheduled to undergo aortic valve replacement. Now these patients had a mix of severe AS and severe AI. The patients all underwent contrast-enhanced cardiac MRI prior to surgery, and they had myocardial biopsies performed at the time of aortic valve replacement. And we can see pretty clearly that there's a very good correlation on histopathology with the amount of fibrosis seen on histopathology correlating to the amount of late gadolinium enhancement seen on cardiac MRI. So overall, we're on the right path if we want to try and use MRI to identify some maladaptive ventricular remodeling. Let's just take it a little bit further and figure out what happens to that fibrosis over time in aortic stenosis. Everett et al. Looked at the natural history of myocardial fibrosis, specifically in a population that only had aortic stenosis, so they weren't mixing it up and including patients with aortic regurgitation like the prior study did. And they evaluated fibrosis specifically as mid-wall late gadolinium enhancement, which is much more specific for cardiomyopathy associated with aortic stenosis, versus, say, subendocardial late gadolinium enhancement, which in a coronary distribution is much more likely to be from infarct. This is data from a multi-center prospective study where 61 patients who had asymptomatic disease, and that's anywhere from mild aortic stenosis or worse, were included in the study. All of the patients underwent at least 2 serial MRI scans. There was a slight male predominance, and only about a quarter of them actually had asymptomatic severe AS. We can see on the results on the left that on average, patients had 2.5 grams of late gadolinium enhancement at baseline, which increased by 1.6 grams per year. Notably, late gadolinium enhancement increases with time, even while ejection fraction remains unchanged. Now, in this figure on the right, we can see that the annualized change in myocardial fibrosis is greater as the disease progresses from mild to severe. So in other words, myocardial fibrosis accumulates at a more rapid pace as aortic stenosis progresses from mild, moderate to severe. They also had a cohort of 38 patients who were symptomatic and needed aortic valve replacements. So these patients underwent an MRI prior to their aortic valve replacement and then a repeat MRI on average about a year after undergoing surgery. And this is just a representative patient's MRI from that study where we can see an increase in fibrosis over time compared to baseline and then 1 year later. And then that fibrosis does not actually reverse after aortic valve replacement. Now, the group also confirmed this finding in statistical analysis as well. But ultimately, what we really care about is how that myocardial fibrosis impacts outcomes. So this was a study from UK that evaluated how preoperative late gadolinium enhancement impacts clinical outcomes after aortic valve replacement. This is a prospective multi-center study, 674 patients who had severe aortic stenosis and were already planned to undergo aortic valve replacement were included. All the patients had a preoperative cardiac MRI. 51% of patients actually had some amount of late gadolinium enhancement present at baseline, and the other half did not. The average age for patients was 75 years with a slight predominance of men. If we look at their analysis, the survival analysis showed that patients with late gadolinium enhancement on preoperative cardiac MRI had higher all-cause mortality following aortic valve replacement. And on multivariate analysis, late gadolinium enhancement was independently associated with a twofold increase in late mortality. And this was again adjusted for age, ejection fraction, STS score, coronary artery disease, AFib, as well as hypertrophy of the ventricle. So I hope you're all somewhat convinced that we can identify replacement fibrosis with an MRI and that it's a useful prognostic marker. But what if we want to try and interrupt the maladaptive remodeling before we reach replacement fibrosis? Essentially, what if we want to try to identify a marker even earlier in the disease process that still has prognostic value? To do that, we can use T1 mapping on cardiac MRI, which is much more sensitive for diffuse fibrosis. So we can use it to identify that extracellular matrix expansion and that myofibroblast infiltration that we were talking about, which is a hallmark for diffuse fibrosis. Everett and colleagues ended up using T1 mapping to try and predict outcomes after aortic valve replacement. So they had 440 patients who were all undergoing aortic valve replacement for severe aortic stenosis, and they included them in their study. All of these patients underwent cardiac MRI prior to valve intervention. Average age for patients was 68 years with, again, fairly even split between men and women. Now they used T1 mapping. Using the T1 mapping, they ended up stratifying the patients into tertiles of extracellular volume fraction. So extracellular volume fraction or extracellular volume expansion, again, as we said, reflects the size of that extracellular space in the myocardium. And here, tertile 3 has the most extracellular volume expansion and tertile 1 the least. On the figure on the left, we can see that all-cause mortality progressively increased as the amount of extracellular volume expansion increased, with a threefold higher mortality in patients who had the most extracellular volume expansion compared to the least. On multivariate analysis, we can see that extracellular volume expansion was independently associated with mortality with a hazard ratio of 1.1 for each % increase in extracellular volume. This was adjusted for age, sex, EF, and late gadolinium enhancement. So to summarize, late gadolinium enhancement on cardiac MRI correlates with replacement fibrosis that's seen on histopathology. Fibrosis increases over time with aortic stenosis, even as the ejection fraction remains unchanged. So the fibrosis can be subclinical, and we might not pick it up if we're only looking at EF. And once you end up getting replacement fibrosis, it's irreversible, even after aortic valve replacement. The presence of preoperative late gadolinium enhancement also portends worse survival after aortic valve replacement. And then lastly, T1 mapping also predicts mortality after AVR, and it's a marker that we can try and use to detect even earlier subclinical LV dysfunction. As with everything else we're going to talk about, there are some caveats to keep in mind. First off, we are extrapolating from studies that did have a lot of symptomatic patients. Secondly, cardiac MRI is not all that widely available as, say, BNP or some of the other imaging studies we're used to using. And lastly, there's really no clear cutoff for when to consider surgery. So if you end up getting a cardiac MRI, it's a little hard to figure out exactly what to make of it. In fact, we're not even sure if it's just the presence or absence of late gadolinium that would make a differentiating factor, or whether or not it's the % myocardium affected or the absolute amount of myocardium affected. And we kind of saw that variability as we were going through the studies, with different studies using different sorts of cutoffs. So it's not exactly prime time in the sense that we can rush to have it try and incorporate into the guidelines. You might be feeling a little bit strained after having been made to look at those figures for T1 mapping and late gadolinium enhancement so early on such a beautiful morning, but that's a perfect mindset for you to be in for our next topic. So since cardiac MRI is not as widely available and echo is, we can take a look at subclinical markers for left ventricular dysfunction on echo. And aside from ejection fraction, global longitudinal strain has also been explored as a tool for evaluating the myocardium in patients who have aortic stenosis. Global longitudinal strain, as we know, just measures the longitudinal shortening of the left ventricle and ends up expressing it as a percentage of the baseline length. So a more negative number means that the myocardium is deforming to a greater extent, which is generally better. And all of this is done via a tracking software. And at the end, we end up getting a map like the one that's shown here on the left that shows us the strain values for specific portions of the myocardium and an average global longitudinal strain value. And we found that global longitudinal strain is sensitive to subclinical left ventricular dysfunction. This is data from a retrospective multi-center international registry. 220 patients that had severe asymptomatic AS were included. About a subset of 150 of those actually underwent serial echoes with strain imaging, with generally a year between exams. These patients had a preserved ejection fraction and on average were 68 years of age, with 57% of them being men. And the results, if we take a look from the top left to the bottom, we can see that as you have a progression of the valve disease, so basically as the aortic valve mean gradient increases, your left ventricular hypertrophy also increases, and left ventricular global longitudinal strain decreases, but ejection fraction remains unchanged. These investigators also evaluated the prognostic ability of global longitudinal strain. So to do this, they ended up separating their entire cohort into two groups. Those that they considered as having, quote, preserved strain versus impaired. They ended up using a cutoff of negative 18.2%. And the way that they arrived at that was the median value of the baseline global longitudinal strain measurement for their entire cohort using their particular vendor for evaluating strain. And they found that over time, patients who have impaired global longitudinal strain developed symptoms and required intervention more so than patients that had preserved global longitudinal strain. But a lot of the studies on strain are pretty small, so this prompted Manya et al. To perform a meta-analysis to, one, evaluate the impact of strain on mortality specifically, and to try and develop a cutoff by using data from 10 different studies. So they actually had individual participant level data in their meta-analysis, and they initially used data from 1,067 patients, basically all the patients in all 10 studies, to try and develop a cutoff for impaired strain. Now, because they included all patients, they had patients that even had moderate AS or worse, and they ultimately identified negative 14.7% as being the cutoff that sort of gave them the best sense of sensitivity and specificity in predicting mortality. Specifically, the sensitivity was 60% using that cutoff, and specificity was 70%. Then they went ahead and applied that cutoff to 875 patients that had severe asymptomatic aortic stenosis in order to evaluate mortality. So these patients all had a preserved ejection fraction, which is again greater than 50%. The average age of the cohort was 74 years, again, decent split between men and women. If we look at the results, we can clearly see that the survival curves show that patients who have impaired global longitudinal strain have worse long-term survival. On multivariate analysis, impaired left ventricular global longitudinal strain was a strong independent determinant of mortality with a hazard ratio of 3.59. And this was adjusted for age, gender, the aortic valve area, and ejection fraction. So in summary, global longitudinal strain helps us to identify patients that have subclinical left ventricular dysfunction, even when they appear to have a quote-unquote preserved ejection fraction. Impaired strain predicts patients that go on to develop symptoms and require intervention, and ultimately, impaired strain is associated with increased risk of mortality. But again, some caveats that we've got to keep in mind. There are technical differences among vendors that can influence the strain value, and you kind of saw this firsthand between the two different studies that we just looked at that arrived at completely two different values for the cutoff, or what should be the appropriate cutoff. This is because vendors have their own proprietary post-processing algorithms to calculate global longitudinal strain, among other differences. The other caveat to keep in mind is that strain technology relies on us having technically adequate windows and, importantly, also a technically adequate frame rate in order for the technology to actually be reliable and reliably track the myocardium. And then lastly, of course, there's no cutoffs, and it's not really clear, should we use an absolute cutoff for strain for when to consider surgery, or rather a change from exam to exam? And then how do we end up reconciling differences in strain values between vendors? We're still sort of relatively early on in the research regarding strain abnormalities in aortic stenosis. And of course, as 3D strain becomes more widely used as well, we may very well have more coming down the line for this. So we've looked at a few different prognostic markers that we can use for detecting subclinical left ventricular dysfunction, and these prognostic markers help us identify patients that might have overall worse clinical outcomes if we sort of just keep following the same clinical paradigm that we have been thus far. But how do we know that intervening on this patient population will actually lead to better outcomes? In other words, is the juice worth the squeeze? To dive into that, we're going to assess the risk of mortality with standard care versus early intervention. So we can just first start by examining the overall survival for this patient population and the risk of sudden cardiac death. This is contemporary data from a prospective multi-center international registry. It included patients from the US, Canada, and Europe. There were 861 patients that had asymptomatic severe aortic stenosis, and they were followed from 2001 to 2014. These patients were medically managed, so they were followed every 6 months to a year. Average age was 72 years with slight male predominance. And as you can see on the survival curve on the left, 2-year, 4-year, and 8-year overall survival rates were 92%, 80%, and 65%. So not perfect. 50% of the deaths were from cardiovascular causes, with heart failure being the most predominant one, and the other half was other comorbidities. The actual crude rate of sudden cardiac death was pretty low in this population, at less than 1% over an average follow-up of 27 months. So the way to prolong life for this patient population is through prevention of heart failure, because their sudden cardiac death rate seems to be fairly low. But the real question is, can we do better by intervening earlier? This study aimed to do just that, came out of Japan, and they evaluated long-term outcomes after an initial aortic valve replacement strategy versus conservative management for patients that had severe asymptomatic aortic stenosis. Again, this is data from the current AS registry. So they evaluated a subset of 291 patients that had asymptomatic severe AS and had early intervention. And then they used propensity matching to compare outcomes with 291 patients that had conservative treatment. The indication for surgery are reasons that we would have already operated on patients according to our current guidelines. And these indications were present in 63% of the patients. So indications like rapidly progressing disease or very severe AS or an ejection fraction less than 50%. Average age was 72 years, and there was a very slight predominance of women. Now, even with propensity matching, unfortunately, their patient population wasn't really all that well matched, so they ended up using an adjusted analysis using Cox hazard proportional model. And they found that the risk of all-cause cardiovascular and sudden death was lower in the initial aortic valve replacement group, as well as a lower rate of heart failure hospitalization. And these outcomes were cumulative over 5 years. So the study's thought-provoking that it might be possible for us to do better early by intervening earlier, but it's a pretty small study. It's retrospective, it's propensity match data, which isn't exactly our gold standard. And of course, as I've already mentioned, a large population of the patients already had indications for surgery that we would be doing surgery for, because we think those patients are better off anyway by intervening earlier. So this takes us to some recently published data from a randomized trial out of Korea, the recovery trial. Now, this was the very first, or is the very first, randomized trial that aimed to evaluate outcomes for early aortic valve replacement compared with conservative management for asymptomatic aortic stenosis. It was published in New England Journal of Medicine, definitely made a splash for being the first kind of trial, first trial of its kind. It was multi-center, open-labeled, and randomized. They ended up recruiting patients that were asymptomatic and had very severe AS. So specifically aortic valve area less than 0.75 centimeters squared, or in addition to a peak valve velocity of 4.5 meters a second, or a mean aortic valve gradient greater than 50. They ended up excluding patients that would otherwise have indications for surgery, like patients who have symptoms or depressed DF or concomitant valve disease or a positive stress test. And they also excluded based on age, specifically patients greater than 80 years. Ultimately, 145 patients were randomized to early surgery versus conservative care. Now, there was a very small number of patients that actually did end up having some crossover. So 4 patients crossed over to conservative care, 2 crossed over to early surgery, and 1 actually underwent TAVR. I've just included the highlights in terms of patient characteristics, some things to keep in mind. So on average, this was a younger patient population with an average age of 63. There was an even split between men and women, but these patients were pretty low risk surgical candidates. The Euro 2 score predicts the risk of in-hospital mortality after surgery, and 0.9% is pretty low. A significant portion of the patients had bicuspid disease, which is probably why the population was younger. And then the average valve hemodynamics were consistent with what we would describe as very severe AS. So average peak velocity of 5 meters a second and average aortic valve area of 0.64. All these patients were followed for 4 years after the last patient was enrolled, and the median follow-up time ended up being 6.2 years. The primary endpoint evaluated was operative mortality within 30 days or death from cardiovascular cause during the follow-up period. And we can see that the primary endpoint heavily favors early surgery. The operative mortality was pretty low at 1% for patients in the early surgery group. And the early surgery cohort also does better when it comes to evaluating secondary endpoints as well. But again, there are some considerations that we've already sort of pointed out or are aware of. First off, patients had, these were patients that had really very, very severe disease. So patients that have a peak velocity, again, on average 5 meters a second in both groups, those who were conservatively managed and those who were intervened upon. And then the patient population was rather young, in their early 60s, and pretty healthy with a low Euro score 2. So overall, this study took a patient population with pretty severe disease and low surgical risk. So it's not entirely surprising that patients with surgery had better outcomes. The one thing we don't know, which is especially important to know when we're operating on younger patients, is sort of very long-term outcome data about how many interventions these patients require later on down the road, and ultimately what their outcomes with those procedures end up being. But nonetheless, this study does lend credence to the idea that we've had all along, that intervening on patients with very severe disease, even if they don't have symptoms, improves outcomes. But it doesn't exactly answer the question of what outcomes will look like for patients who have slightly less severe disease, which is ultimately what we set out to do at the beginning of today's talk. To do that, we're going to have to look at trials that are coming down the pipeline. So let's just go over our final objective. Now, this is by no means a deep dive into the nuances of surgical aortic valve replacement versus transcatheter aortic valve replacement, but rather just a broad strokes acknowledgement of the challenges we face when we see a patient in clinic and we're trying to determine whether intervention and then which intervention would be most beneficial for them. We're often balancing the risk of the intervention itself with short-term and long-term outcomes, and there is some amount of clinical equipoise about which modality to use in which circumstances, with pros and cons on both sides. As we think about intervening earlier, we also have to consider the subsequent interventions that would make the most sense for a patient. Again, I just want to emphasize we're lucky to be in an era where we have these options, and I want to go back to one of the main concepts that we discussed at the very beginning. The only reason we're actually having a conversation and debating now about early valvular intervention is because there's been an evolution in treatments that have fueled the thought process. It is undeniable that TAVR coming onto the scene has changed the face of valve replacement, but it's also undeniable that surgery today does not look like surgery decades ago. So it's no doubt that as treatments continue to evolve, our timing for intervention is going to continue to change as well. Now, these are all of the ongoing trials that are evaluating early intervention versus watchful waiting in patients that have asymptomatic severe aortic stenosis, and all of them are going to evaluate mortality as an endpoint in some form or another. On the right, we have the early TAVR trial. That's the only one that we're actually a center for and the only one that's recruiting in the United States. And it's specifically evaluating whether early TAVR leads to better outcomes versus watchful waiting. So none of these patients are going to get surgical intervention. On the other side, Avatar and Estimate will only evaluate early intervention with surgery, whereas the rest will look at both types of interventions. I just want to draw your attention to a couple of these trials specifically. So the Danaver trial hasn't started recruiting yet, but it's a trial that's taking place in Denmark. Part of their inclusion criteria is to specifically try and recruit patients that have subclinical left ventricular dysfunction. But it's pretty liberal criteria, as you can see. Overall, I think it's going to be interesting to see if using that inclusion criteria helps them to find a patient population that's more likely to benefit from early intervention. Based on what we've talked about during this talk, I think that it will. And then the second sort of unique trial is the Evolve trial. All of these patients that get recruited for this trial are going to undergo a cardiac MRI. Those that have mid-wall fibrosis will end up getting randomized for early intervention or routine care. And those without fibrosis will either get routine care with study follow-up or without study follow-up. Again, it's going to be interesting to see if it tips the scale in favor of intervention. And my guess is, again, that it will. So going back to our hypothetical case, I hope I've convinced you that you should be thinking about whether or not you need to intervene on this patient earlier and what markers you might want to try and use to identify whether this patient's going to benefit from early intervention. This is, again, the usual algorithm that we follow for patients who have asymptomatic severe aortic stenosis. And based on what we've discussed today, we can add another arm to this algorithm. So for patients that we struggle with to identify symptoms, we can consider these other subclinical markers that help to identify patients that have worse outcomes when we wait to intervene. Now, again, there isn't data to say definitively what cutoffs we should use with these markers or exactly what we should do with this patient population when it actually comes to intervention. But I just want to emphasize that if you're working through the gray areas in clinical practice and you're feeling stuck or unsettled about a patient, these are still tools that you can have in mind when you're thinking about trying to tailor management for a specific patient. We know that they're not all prime time and they can't be incorporated into the guidelines right now, but it's still something that you can at least have in mind. And just know that we've got trial data coming down the pipeline that's going to help to delineate what we should do going forward. So the conclusions for today's talk, first off, maladaptive ventricular remodeling accompanies aortic stenosis and leads to heart failure and death. Ideally, we want to interrupt this process by intervening earlier, and we hope to have better patient outcomes by doing so. Second, elevated BNP, impaired global longitudinal strain on echo, and abnormal T1 mapping and late gadolinium enhancement on cardiac MRI can all identify patients that have subclinical left ventricular dysfunction and elevated mortality risk. Again, the exact thresholds of when we trigger intervention still needs to be worked out, and BNP is actually probably just the closest we have to actually getting incorporated in guidelines, whereas strain and MRI still have some more significant research to be done. Randomized trial data showed mortality benefit for early AVR in very severe AS, but its role in higher risk patients and less severe AS really remains to be clarified. And finally, there are many randomized trials that are underway, and we're likely overall moving towards earlier intervention to minimize mortality risk. I have a really long list of people to thank for their insight and feedback while putting this talk together, and honestly, an even longer list of people that I want to thank for their contribution during fellowship that I cannot possibly fit onto one slide. So I just want to say thank you to my mentors for helping shape my career. Thank you to the attendings I've worked with that have helped me grow clinically, and thank you to my co-fellows for their endless support.